Hello everybody and welcome to PanKind's EmpowerEd webinar, Pancreatic Cancer Diet Nutrition Overview. My name is Sophia Casbolt and I'm PanKind's Program Manager. Thank you so much for joining us today. So I just have a little bit of housekeeping to go through before we start. I need to let you know that the information presented in these webinars is of a general nature and should not be considered personal or medical advice. Always seek independent advice relevant to your specific situation. The opinions of the presenters are their own and do not necessarily reflect the views of PanKind. If you experience any technical difficulties during the webinar, please do let us know via the Q&A chat bar on the right of your screen, or you can email me at sophia@pankind.org.au. A recording of the webinar will be available from our website after today, and only those presenting on screen will be in the recording. During the webinar, attendees' mics and cameras will be off. So I'd just like to extend a very warm welcome to our presenters for today, Amanda Landers and Helen Brown. Dr. Amanda Landers and Helen Brown. Dr. Landers is leading an Australasian research team called the PERT trial team, who are looking at enzyme replacements in pancreatic cancer. She's a senior clinical lecturer at Otago Medical School and loves to teach people about palliative care. Amanda was born and bred in Waikato. The Deep South is where her passion for palliative care began as a house surgeon. She enjoys talking with patients facing life-limiting illnesses, helping them to plan and prepare for the future and making sure symptoms are well managed. She has worked in Wellington and in Darwin in some extremely remote environments. Helen Brown currently works as a community dietitian at Nurse Maud Hospice Palliative Care Service in Christchurch, and is also part of the PERT trial team. In her job as a palliative care dietitian, she sees patients across Canterbury with a range of life-limiting illnesses. She has a particular interest in the care of patients with pancreatic cancer and is involved in research in the area. She's been invited to lecture at Canterbury University in postgraduate palliative care program and presented on pancreatic cancer at conferences nationally and internationally. So today, I'll just jump through our agenda really quickly. So our lovely presenters are going to be talking about managing diet and nutrition when you or a loved one has had pancreatic cancer, a background on what the pancreas does and how pancreatic enzymes work in the body, as well as tips on how to get the best out of your pancreatic cancer enzyme replacement therapy, and information about the PERT research trials group and how the results may help people with pancreatic cancer. After the presentation, we'll have around 15 minutes for questions. Please send through your questions at any time via the Q&A chat bar on the right of your screen. And if questions come up that you also want answered, you cannot vote them in the chat. Questions most relevant to today's topic or more general in nature will be prioritised. If you have any questions that are specific to your circumstances, these are best directed to your healthcare team. All right, well now I'm going to hand over to Helen. And I'll just pop up your slides, Helen.
So to start off today,
Right.
I thought it would be helpful if we started off with a bit of basic anatomy and how does digestion work and how does the pancreas work. So if we opened you up like a book, this is what you would look like inside. For digestion to happen normally, you need food to come down the esophagus into the stomach, where it gets churned up and transfers into the duodenum, which is the top of the small intestine. The head of the pancreas is where most of the cells are that produce the digestive enzymes, and they're transported by the tiny pancreatic duct, which joins the bile duct, as you can see, just as it enters the wall of the small intestine. The digestive enzymes then break this food down small enough so it can be absorbed through the gut wall and the body can use it for repair, energy, keeping weight on, and things like that. Okay, so the pancreas has two major roles. It produces enzymes, and there's the three enzymes. There's amylase, which breaks down carbohydrate, protease that breaks down protein, and lipase that breaks down fat. The other thing to note is that amylase is naturally in your saliva, so you actually start digesting your meals in your mouth. The most important enzyme that we look at when we're looking at healthy digestion is lipase. If we get the dose of lipase right for the meal you're eating, the doses of the other two will be correct. Okay, so now we move on to pancreatic cancer. Amanda.
Well, as you've probably noticed, we are both from New Zealand, and we often say Aotearoa New Zealand. And so I did a little bit of homework looking at your Australian statistics around pancreatic cancer, and I found these, they're very recent, 2021, and it appears that just over 4,000 Australians are diagnosed with pancreatic cancer each year, and that's just under 3% of all cancers. So it's not a very common cancer. It's reasonably uncommon. And it's estimated to be about 7% of all cancer deaths in the year of 2021. So although it's reasonably rare, it's still the 5th most common cause of cancer death in Australia. It equally occurs in both males and females. So the incidence is seen in both of the genders. And usually it's in the age of sort of the 70s or so. Although I did read that the age of pancreatic cancer is actually decreasing, not increasing. And there's something quite unique about pancreatic cancer. The way that it affects digestion, it means that it causes quite significant weight loss. And something that's called malabsorption, which Helen is going to go into a little bit more, in the vast majority of people diagnosed with this cancer.
So if we go into food malabsorption or maldigestion, you may also know of it as, you can get malabsorption from having pancreatic surgery. You may have a Whipple's procedure, which is removal of the total pancreas, or a variation of this. There may be a blockage of the pancreatic duct because it's so tiny, we can't stent it. So if that becomes blocked, then the enzymes can't get to where they need to go. Or the cells that produce the enzymes may be obliterated by tumour. Therefore, the enzymes aren't able to be produced. And with patients with pancreatitis, they also have malabsorption. And the overall result is weight loss. And in some patients, steatorrhea, although steatorrhea is a symptom of advanced malabsorption. So it's usually when somebody's been malabsorbing for a period of time.
And Helen, what's steatorrhea?
So steatorrhea is diarrhea, but particularly fatty. So you may find that when you pass the bowel motion, it's looser, and it may leave a oil slick across the top of the water, and it may also be difficult to flush. Okay, so what are the symptoms that appear with malabsorption? And it's really the presence of the food that causes the symptoms because it can't be digested properly. So undigested food is going into the small bowel, and the small bowel doesn't like undigested food. So you may have pain, or a lot of patients say it's not really pain, it's discomfort after eating. And it may escalate over the day. So when you get up in the morning, you've had 10 or 12 hours without eating, so everything settles down. As soon as you start eating, the discomfort starts to escalate. So by the end of the day, somebody might be really uncomfortable, not know where to put themselves, not feel like eating the evening meal. They go to bed and they can't get comfortable in bed. There may be an increase in flatus or rectal wind. And the noticeable thing about it is the odour of this wind is quite distinct. It's an undigested sulphury smell and quite obviously different from normal flatus. Some patients may suffer heartburn or may find they belch more. Once again, undigested food in the bowel, the wind has to go somewhere. Weight loss is definitely a problem. change in bowel habit is a problem. For people who are on pain reliefs that tends to constipate, they may not notice steatorrhea because it will be masked, but they may notice that their bowel motions are pale because of the presence of fat that's not being absorbed from the food. And because of the fat content of the stool, they'll float. So in actual fact, keeping an eye on your bowel motions is a good indicator as to whether further down the track when we talk about medication, whether you're taking enough of that medication or not. So what can we do for people who have pancreatic cancer? Well, there is a medication that you can take, and the most common one available now is Creon. That's readily available in Australia and New Zealand. So the most common dosage that I tend to use in my practice is Creon 25,000, and that means there's 25,000 international units of lipase in that capsule, along with the other digestive enzymes. The reason I tend to use the Creon 25,000 is it reduces the drug burden that I put on patients. If I use Creon 10,000, of course, I would need to use more capsules to get the right dose. So by using Creon 25,000, we can keep the number of pills that you have to take down. It's important to note that the base of the capsules is porcine or pig-based because pig cells are so similar to human cells. But for somebody who culturally can't have pork, it's important that they're aware of this. The dose that somebody needs to take is determined by the fat content of the meal. But of course, we don't expect you to analyse out the fat content of your meal because you have a low appetite anyway, and that would make eating even less enjoyable. So we tend to go with a baseline dose of perhaps 2 with meals, 1 with snacks, and then titrate your dose up depending on symptoms. Another thing that's important to know, if you have a sulfur drug allergy, which is quite rare, and the number of drugs that are now around that have sulfur in them are relatively low. However, Creon does have sulfur as a byproduct of production. So if you do have a sulfur drug allergy, you do need to be conscious of that. And I've recently had a patient who had numerous drug allergies and wasn't aware that she had a sulfur drug allergy and did react to Creon, and we had to change her to an alternate medication that didn't have sulfur as a byproduct. Now, it's important that you take Creon or digestive enzyme replacement therapy with all meals and snacks, because if you only take it with meals, you'll be symptomatic in between, and you won't be able to tell if you're actually on the right dose of medication. However, there are some foods, like everything, there's an exception to the rule. There are some foods that you don't need to take Creon with. So if you're having a piece of fruit between meals, you don't need to take Creon with that. If you're having jelly, you don't need to take Creon with that. If you're having fruit juice or a fizzy drink, you don't need to take Creon with that. I have had 1 or 2 patients who have found that if they have a biggish piece of fruit, they're a little bit symptomatic. So as we say always, everybody's an individual. So if you don't take it with fruit and you notice that you're a little bit gripey afterwards, perhaps next time you have a piece of fruit, you take it with it just to see if it makes a difference.
So Helen, that means that if I am going out and I'm having a slightly bigger meal or a fattier meal than I would at home, I would just take extra Creon?
Yes. So if you're going out for a meal and you don't know what's in the meal, you're going to a restaurant or you're going to a friend's place for dinner, you're better to slightly overestimate the dose to compensate for not knowing what's in the food. It's a very safe medication, very few side effects, and so you're almost better to just overestimate a little bit so that you stay symptom-free. From the same point of view, if you're a slow eater and your meal tends to stretch out a bit longer than normal, it's better to perhaps take some of your Creon at the beginning and some at the end of the meal so you drag out the peak action time. Remembering the reason for picking the dose you take is dependent on the fat content. So it can vary depending on what people are eating.
Okay, so if I was having a fairly biggish meal and it was going to take me quite a long time to get through it, I might have like 2 Creon before.
Yes.
And 2 Creon in the middle.
Yes. So further down our presentation, we actually talk through if you're eating quite a big meal. But also I'd just like to mention, sometimes on a Friday or Saturday night, if you've got friends around and you don't have a specific meal, you tend to graze on a platter. What should you do about Creon in that situation? Mm-hmm. And what I would tend to say is start with a dose of Creon, and then every 3/4 of an hour to an hour, drop another Creon in so that you're covering that grazing behaviour. Mm. And that will cover you for a snack platter.
Oh, great. Thanks, Helen. There we go.
Okay, so as we mentioned before, if you're having a large meal, split dose your Creon. And the reason we say that is that the peak action time of the medication is the first half hour. So by split dosing, you drag out that peak action time. You might take 2 at the beginning of the meal, 2 at the end of the meal. It covers you for that larger meal that you're having. And that's why it's also important that you take the medication as you sit down to start eating, not half an hour before a meal like you may take anti-nausea medication. It's important not to crush or chew the medication, because if you chew and break those protective coated little beads inside the capsules, you expose the enzymes. And then once the enzymes hit the gastric acid in the stomach, they're deactivated and it's useless. So it's been a waste of time taking the capsule. Also, if you chew it, you can irritate the inside of your mouth. So if you're breaking open the capsules, make sure you swallow them whole. Where it can be helpful to open the capsules is if people have a problem taking capsules, and not everybody finds this easy. So if you're finding that taking capsules may make you dry reach, or you struggle to take capsules, keeping in mind that you may be taking 2 or 3 or 4 of these, then open up the capsules and put them into an acid-based food. Now, an acid-based food is something like sieved apple, pureed vegetables. So it's quite helpful to have a little jar of sieved apple in the fridge so that you can take it easily. Some rest homes will choose to give patients medication and open the capsules and give their patients medication like this also. However, usually when we explain to people who have trouble taking medication, we say put it in basic foods like custards, yogurts. However, if you put the Creon beads into custard, because it's a basic type food, the special protective coating is going to wear off, exposing the enzymes. So once again, when the enzymes hit the stomach, the gastric acid will knock them out. Another thing that's a helpful tip is not to put your Creon capsules into blister packs, because if you snap off a little bubble and go out and take the rest of your medications while you're out because they need to be taken at a certain time, and you don't then eat immediately, you've lost that peak action time again from your Creon capsules. So wherever possible, keep your Creon capsules out of blister packs and in a bottle separate. And it's really helpful to have a little bottle in your handbag or in your pocket when you go out, so that if you are out longer than anticipated and you call into a cafe to have a coffee and something to eat, you've got your Creon capsules with you. The other thing it's important to remember is that Creon doesn't constipate, but it corrects bowel habit. So before you know that you're malabsorbing, you may not need to take your laxative regime because your bowels are slightly looser than normal because you're malabsorbing. However, once we put you on Creon, it corrects that bowel habit, and you may find, because you're on some other medications that tend to constipate you, you're now in a problem of constipating. So I always say to patients, once you start taking Creon, be mindful of what your bowels do. And if they firm up a little, put your laxative regime back into practice so that you don't become constipated.
That's great. Thanks, Helen.
Okay. It's really helpful to know, and you can ask your dietitian or doctor, what is the maximum dose of Creon I can take in a day? This helps give you confidence that you can titrate your own dose of Creon depending on what you're eating, and that's going to vary meal to meal, snack to snack. But it also makes you realize that you're not running yourself into danger of going toxic on it or anything like that. It's a very safe medication. And I always tell my patients what their maximum dose is, keeping in mind that they're never going to need to get to their maximum dose. And when I tell patients what their maximum dose is, they're quite horrified by the number of capsules they could take in a day. But often they're only needing to take perhaps up to half of that dose. But it's helpful for you to take control back over your own management by knowing what your maximum dose is. Now, it's really important that you don't take pancreatic enzyme replacement therapy with calcium or magnesium supplements, medications, because they tend to bind together and render both of them ineffective. So you need to pull the Creon away from calcium, magnesium medications. Now, another medication that can be really helpful when taking Creon for malabsorption is omeprazole or pantoprazole. And the reason for this is we know that your stomach sits at an acid pH, so a pH of about 1 to 5, which is acidic, and we know that because of gastric acid. We want the Creon capsules to go through the stomach undamaged. The capsule will come away in the stomach, but as I mentioned before, the beads are protective coated, so that gastric acid isn't going to damage the enzymes inside those little beads. Once the beads get into the top of the small intestine, we need that environment to be basic so that the enteric coating wears away and you can use your enzymes on the food you've just eaten. But sometimes you get a little bit of gastric acid overflow into the top of the small intestine. So if we start you on Creon and we get you to a dose that we think is really good for you with the food you're eating, and we still don't seem to have as good an effect from the medication as we should, we can put you on omeprazole or pantoprazole, and it acts like a buddy drug for Creon. It helps with the effectiveness of your Creon by making sure the small intestine, where the enzymes need to be effective, is in a basic state. Okay, so what should you be eating once you've been diagnosed with pancreatic cancer? So first off, don't restrict fat. There will be some meals that you just can't face anymore, that just don't sit well with you as an individual. But as an overall rule, you shouldn't restrict fat because you're probably eating less than you used to eat. And so fat ends up being really quite an important calorie provider. Try to eat nourishing meals and snacks, and try and have protein with every meal so that we're repairing damaged cells. When you get a meal, try to eat the most nourishing part of the meal first so that you don't fill up and then find you can't eat the most nourishing part of the meal. And from the same point of view, don't drink a load of fluid before you have a meal, because you'll fill yourself up and then not be able to eat the meal. When I go and see patients, I always ask them what is their best time of the day for eating, and it varies by the individual. But for a lot of my patients, the best time for eating is first thing in the morning. They're most rested, and they possibly will have a little bit of an appetite. So if that's your best time of the day, then that's probably going to be the meal you'll fortify the most, because we can't expect that you're going to necessarily eat a big volume, but you can make the most of the food you're eating. For instance, if you're having porridge for breakfast, make it with milk rather than water. Put a little bit of cream on the top if you can tolerate cream. Use ready-made meals to your advantage. So check out your local deli, go to your supermarket delis, look at the ready-made foods in the supermarket. You'll have a window of time where you feel like eating, and it won't be very big. If you're waiting 3/4 of an hour to an hour for a meal to be prepared for you, you lose that window of time and you lose that opportunity for eating. So it's really important to use convenience where possible. And it might be once a week you have a takeaway meal of some sort, whether it be a bought roast meal or a Chinese takeaway or something like that, to give yourself and your carer time off. When you're well, we tend to say nutritionally, sit down at the table so that your brain recognizes you're eating a meal. But when you become unwell with a cancer, it's really important that we flip that on its back and use things like distraction to ensure that you eat better. So you might have your meal in front of the television watching the news, and being distracted, you may eat more than you would have eaten if you were sitting just focusing on the meal. Having relaxing music going in the background. And generally people eat more when they're eating with company. So if you live on your own and you live next door to somebody, having company can be a real benefit for you. If you have a rest mid-afternoon, like a lot of my patients do, and you may sit down and just watch TV or rest on the couch, read a book, then actually having a snack plate beside you while you're having a rest, you'll actually put away more food than you're aware of by just grazing. Talk to your dietitian or doctor about using nutritional supplements. Wherever possible, we do food first because that's our quality of life stuff. Everything we do celebration-wise is around food. But nutritional supplements have a place in the picture. And if it's something that you enjoy, it can be a real boost to your calorie intake. Make sure you're getting a variety of food. If you're just focusing on one food that you can currently eat, you can get flavour fatigue. And then when you get over that, sick of that food, what do you do then? So by mixing it up a bit and having variety helps you as far as selection. And if you have a range of ready-made foods in the fridge, pantry, freezer, it means that when you think you can eat something, you can go and browse what you have available, and it's easily ready for you to eat. Okay, so what happens with nutrition if you have a Whipple's procedure? What is a Whipple's procedure? It's where the surgeons remove the head of the pancreas, where you produce a lot of your digestive enzymes, the duodenum, which is the top of the small intestine where you absorb your nutrition, the gallbladder, the lower bile duct, and sometimes a portion of the stomach. Now that's a full pancreatectomy. You may have a variation of that. You may have a distal pancreatectomy where they only remove the body and maybe the tail of the pancreas, or they may do a bypass where they can't actually remove the tumour, so they do a bypass around the tumour. Specific dietary advice for somebody who's had surgery like a Whipple's is eat small, frequent meals. They're better tolerated. Don't drink with food because you fill yourself up, but also you tend not to digest your meal as well. And you may also end up having dumping syndrome. Monitor your weight. If you notice your weight is slowly slipping down, see a dietitian if you have one close by, or practice nurse or GP if there isn't a dietitian available. Straight after your surgery, you may need to avoid really, really high fat foods, as these may not necessarily be tolerated initially, but gradually over time you may be able to increase the fat content of your food. And definitely reduce your Creon dose depending on as you slowly increase the fat content of your diet. So what is dumping syndrome? You suffer a fullness, you feel flushed, sweaty, you may have a racing of the heart, and you may have some diarrhea 15 to 30 minutes after eating. And it's a result of the food coming out of the stomach too quickly and going through the intestine too quickly. So a way to help yourself if you're suffering from these symptoms that are really quite unpleasant, avoid large meals. Avoid high sugar food because it draws fluid into the intestine to neutralize it. Avoid drinking with meals, as I mentioned before. And you can try opening your capsules so that you can help the Creon be absorbed more quickly, thereby being more effective. Cancer affects people differently, and if you're losing weight and don't know what to eat, or have ongoing trouble with symptoms, or feel anxious about eating, ask to be referred to a dietitian. Amanda.
Thank you, Helen. Okay, so I just wanted to talk to you a little bit about our ASPERT research group. So Helen and I started it about 12 years ago when we went to a journal club, which is where people present a research study or a journal article about pancreatic cancer and malabsorption. And we realised that we didn't think it was being done very well in our region, and we wondered how it was being done globally. And we started to have a look and investigate, and that's how the ASPERT group was born. And we aspire to be experts in pancreatic enzyme replacement. So ASPERT is a play on aspire and experts, but it also stands for Aotearoa Australia Pancreatic Enzyme Replacement Therapy Research Group. It's a bit of a mouthful, so we just call it ASPERT. And our mission statement is to ensure all New Zealanders and Australians with pancreatic cancer are assessed for and offered PERT alongside a dietitian review. So that's why we do all the work that we do in this area, to try and work towards that mission statement. So what did we do? Well, back in 2012, 2013, we had a look at all the people that had been referred to us at our palliative care unit with pancreatic cancer, and whether or not they had been started on PERT or Creon, which is the most common medication. And we published this article in the British Medical Journal, Supportive and Palliative Care, in 2014. And we found a few interesting things. This is one of our tables, and you can see the very large bar on that bar graph is 69% of people referred to us were not on PERT. So these were all people with metastatic cancer that had spread beyond the pancreas that had been referred to us. So only 20% of these people were on PERT, and almost 10% we weren't sure. So it's likely that there were even less people that had been started on PERT. One of the things that Helen and I found when we looked at the people that had been started on the enzymes is quite frequently it wasn't the right dose or the right frequency, or more importantly, people didn't know why they'd been started on it. And so we really identified that there was a bit of a gap or a problem in our cancer community. Of those patients that weren't on PERT, we found that the vast majority of them had symptoms of malabsorption. So much like Helen just described, we found most people had abdominal pain, and almost 1 in 5 had problems with wind and bloating and diarrhea. And so one of the things that really drives us is that we want to improve symptoms for people with pancreatic cancer, and this will then improve quality of life. We then went on to do an interventional study, a study where we actually did something with the PERT. And what we did was we asked people what their symptoms were and their quality of life was when they were initially diagnosed. And then we started them on PERT. Helen went around and started everybody who was referred to us with pancreatic cancer on the enzymes, and everybody got best practice. They got really good information, they got their weight monitored, and we used quality of life questionnaires. And once they had been well established on PERT, we re-asked them their symptoms and their quality of life. So it was a before and after kind of study. Now, even though it took a lot of time and effort, The design wasn't the best it could be because we didn't have a control arm. And what I mean by that is we didn't have a group of pancreatic cancer patients that we didn't do the study in so that we could compare the two groups. And the reason we haven't been able to do this kind of study is because the enzyme replacement therapy is actually written into standard guidelines all over the world, but don't appear to be being followed. And so we can't have a control arm where we have a group of people that are not offered the enzymes. That would be unethical. So we now have to try and find ways of proving to our colleagues and our fellow clinicians that PERT is a really important medication for people to be put on. So what we found in our interventional study and the group of patients that we did give PERT to, and we checked before and after what happened, we found that the vast majority of them had an improvement in their diarrhea. They had a vast improvement in their pancreatic pain, in their liver symptoms, and in their bloating and gas, which is what we would have expected. So it was kind of reassuring to know that the things that we expected actually happened, but also that PERT seemed to have quite a significant effect on people's quality of life. We then did a bit of a change in tack, and we actually did a qualitative study where we asked people who were taking PERT what it was like. So it's really important, we think, to go to the source and for the people who are actually taking the medicine to be placed as experts in this particular area of medicine. And so we asked them what it was like to take the medicine, how it was started, who talked to them. And these were all people with advanced pancreatic cancer. We found we needed 12 people to interview to get most of the information. A qualitative study is quite different to a numbers study, where the more numbers, the better. With a qualitative study, it's more about the conversations. And when you start to hear the same things in the conversation, you know you've kind of got the right number of people. And what the patients or the people were on PERT told us was 4 things. The first thing was they actually already came to the consultations about PERT with knowledge. They had some understanding that often wasn't validated. They had done some reading. They'd had personal experiences of pancreatic cancer. And so they were already kind of primed to start this road or journey of taking PERT. And we also found in our study that people had really high health literacy. And what I mean is they had extraordinary knowledge of their own health, of pancreatic cancer. They understood what the surgeons had told them, and also understood the importance of the medication. And so patients and people with cancer are not to be underestimated in the knowledge that they have. They also told us that the PERT medication changed their relationship to food. And we heard some pretty amazing things like patients calling them their miracle tablets, and also people being able to go and have KFC, Kentucky Fried Chicken, when they hadn't been able to have it before. And so it really did change people's relationship with food. They felt they could go out and have a meal and not be running to the toilet constantly. So we felt even more passionate about making sure everybody in our 2 countries gets good access to this medication. And I guess most importantly, people told us that it wasn't burdensome once they knew what the medication was for, and once they had control of it themselves and could titrate the medicine to their own symptoms. And so I think that's a really important thing, is for clinicians to give the power back to the person, to give good information and education, and also to monitor and answer questions so that people can do it themselves. So as PERT kind of grew past Helen and I, as you can see. So this is the Australian team now. And so we're 12 years down the track. And we now have a group of wonderful clinicians in Australia that helps us research this area. from a range of specialties, and we also have consumers on the group, both with pancreatic cancer themselves, but also having looked after a loved one with this particular malignancy. We've got dietitians, surgeons, oncologists. So this is the Australian group. And here we are in the New Zealand group, Amanda and Helen at the top. We have some great research assistants doing work for us and with us. And we also in New Zealand have a Māori liaison person who keeps us on track in terms of making sure our material is relevant and engaging for all people, all ethnicities, all socioeconomic levels. So what are we doing now? So we're really quite busy still doing this work, and over last year and a bit of the year before, we decided to do a systematic literature review. We wanted to see every single paper that had been published on the impact of PERT on people with pancreatic cancer. And so we got a team together and we're ready to start working. And then we found only 12 papers. So in the global literature, as of 2021, there are only 12 papers published about this particular area. And they were all different kinds of research designs, so it was pretty hard to compare them. But what we found is that PERT shows the potential to improve symptoms, improve nutrition, help with weight loss, and maybe even survival. But really high quality studies have not been done. So what we've got open at the moment is an Australasian survey of patients who are taking PERT. So if you have pancreatic cancer and you're watching this and you haven't undertaken our survey, that would be so awesome if you would. I'll give you the link to go to in a minute. So what we're doing, we want to know what's happening on the ground. We thought if we went to clinicians, we'd get a picture of what clinicians think, but we really wanted to get a picture of what was happening for people with pancreatic cancer on the ground in our two countries. So we have a 6 to 7 minute survey that's open. You just go in, there's a few demographics, and then if you're not on PERT, that's fine, you just tell us that. If you are, the survey goes on to ask you about how you're taking it and who prescribed it. It will only take 6 to 7 minutes to complete, and it really will have an impact on what we do next in terms of our mission statement, making sure everyone gets access to this medication. So if you know of anyone who's got pancreatic cancer, please chat with them about it and ask them if they have a few spare minutes to fill it out. So currently, our goal was to try and have 300 Australians fill out the survey. And as of this morning, we have 91 and 100 Kiwis, because of course we have less numbers. And as of this morning, we're actually at 96. So we're certainly getting close to our goals, but the more the better, the more information we have, the better, because then we'll be able to make a better plan with the voices of the experts, being those with pancreatic cancer. So if you put www.pancreasstudy.com into your web browser, you'll get sent to the University of Technology Sydney website, who host our survey. And then you scroll down to the Australian link and just go straight in and fill it in. Or if you know someone with pancreatic cancer, just send them a wee message with that link in it. But we're not stopping there, because we still need the piece of the puzzle, which is what the clinicians are doing out there. We want to know what's happening for people on the ground, but we also want to know what clinicians understand about enzyme replacement, how they're using it. And we've been able to partner with a master's student from the University of Auckland, who's going to be putting the survey out to both Australia and New Zealand really soon. It's just going through ethics at the moment. And so we will have both parts of the puzzle, and we'll be able to clearly see what the gaps are, what the issues are, and where we need to target our education and information. And we're really committed to making sure rural and remote, urban and metropolitan areas are all covered as well. So our future plans are, towards the end of the year, we're going to come together for the day across the 2 countries and look at the results and put our energy and time into the best way forward. We want to fulfill our mission statement, and we want to make sure no matter where you live, how old you are, what ethnicity you are, or who is looking after you, that you do get at least an assessment for the need for this medication and a dietitian review if possible. We would love to hear from you. We are on Twitter, we are on Facebook, we have an email address. So if you have any questions from today and you don't want to put them in the chat today, please feel free to contact us. Have a look on Facebook, the links are there. Like, share. We are on Instagram as well. We've got Helen, a little video from Helen talking about malabsorption, and she's going to give us a series of little 30-second to 1-minute videos about this topic. And finally, we just want to really thank PanKind for having 2 Kiwi women to give this webinar. Our hearts are with you in Australia, and we really do include you in all of our work. We think of this as an Australasian research team, which it is. And so we meet with Australia regularly, and we thank you again for having us.
Thanks, everyone.
Thank you so much, Helen and Amanda. Just gonna mute you for 1 second. So, oh, there we go. That's working now. Perfect. So I just want to say thank you so much. And we do have quite a few questions in the chat. So I'm just going to pull those up. If you're able to answer some of those now, that'd be wonderful.
Sure.
All right. So let's see. So someone's said they usually eat quite leanly. So lean protein, veggies and salad, and they do follow the rule of 25,000 Creons per meal. But they are still getting loose bowel motions about half an hour up to 3 hours after eating. And they find that the Creon doesn't really seem to be making a difference. And is there something else that people with that should be doing? And a few people have actually upvoted that one. So it seems to be quite an issue.
Okay, so first of all, I would say check the time that you're taking your Creon. Is it just as you start your meal? Try split dosing it. You can try, because sometimes when people eat, if the Creon gets to the duodenum before the food, it's gone more quickly, and so it's not as effective. So if you're worrying that might be the case, you may try Creon midway through a meal. You could try breaking it down and putting it in apple sauce and taking it that way. The other thing I would say is try increasing your dose. If you're taking it at the right time, increase your dose up. 2 25,000s at a meal is very much a starting dose. It's a low dose. So you've got a low threshold for increasing your dose. I would perhaps take it up to 3, maybe 4, and see if that makes a difference. If that still doesn't make a difference, talk to your GP or your dietitian about having the omeprazole or pantoprazole prescribed to see if that will increase the effectiveness of your Creon capsules.
Yeah, there may be other formulations of omeprazole and pantoprazole in Australia.
Yes.
So just use the word omeprazole to your doctor, and then find out what particular flavour of omeprazole your doctor might prescribe. So you may have different names.
Yes. Yep.
And can I ask, what is it that those drugs do?
What they do is they reduce gastric acid. So they reduce any gastric acid getting into the small bowel so that it's in that basic state. So your stomach sits at a pH of between 1 and 5, depending on what stage of digestion you're at, and that's an acid environment. But in the duodenum, the optimal environment for those enzymes is 5 to 7. So it's, within a short distance, you've gone from an acid environment to optimal basic. So you can see that there is an opportunity for it to be not optimal if there's some acid overflow. So that's where your omeprazole or pantoprazole or like medication will help increase the effectiveness of your Creon.
It drops the acidity.
Yep.
Fantastic. Thank you for that. And we did have a comment in here that was saying that, and actually we are aware of this, there is a bit of a shortage of the Creon 25,000 at the moment. And we do know that is supposed to, I believe the supply will return to normal in sort of the next few weeks or so. But just so that people are aware, they may need to speak to their doctors or pharmacy about getting that.
We got an email here in Christchurch saying that there was a shortage of supply. However, when I contacted our hospice pharmacist, she said, luckily, our warehouse still had a good supply, but I'm aware that there has been a shortage, and we were being advised to prescribe Creon 35,000 as a replacement. So I'm not sure what clinicians over there are being recommended.
But I did look at the Australian formulary, and you do have a 35,000 and a 40,000 capsule.
Yeah.
So hopefully between you and your doctor/dietitian, you can work out the units to suit you.
Yeah.
And as Helen says, it doesn't matter if you overshoot.
Yep.
You're probably better to overshoot than to undershoot, because it's such a well-tolerated medication.
Yeah. Remembering looking at that slide we showed where there was, I can't remember what the size of lady was. She was about a 50-odd kilo lady, and her maximum dose was 26. For most people in that situation, I would see them being on maybe 12, 14 max over a day. So you've got plenty of safety room for movement within that maximum dose.
Yeah, that's fantastic. Thank you for that. Somebody also has asked if the Creon enzymes are porcine or just the capsule itself.
The enzymes.
Yeah.
Okay.
So the enzymes are created from pig pancreas.
Yes. Yeah.
So we haven't had too many problems, but as Helen said, there are some cultural practices where it would be really important to.
And often I've found we need to let patients know for that reason, but often it means they can then go and speak to their cultural lead, and for health reasons, often there can be exceptions made, but that's for an individual to decide.
Yeah.
Absolutely. And somebody has also asked, what sort of foods should be avoided if you have pancreatic cancer? Are there any that should really be avoided?
For my patients, I tend to say there is no food you can't have, but there may be some foods that don't sit well with you now. And people generally work out pretty quickly, or they just can't even face it. The thought of it turns them off. So I tend to use the rule of restrict as little as possible, but there will be some foods that you just don't feel like, or you try them once and they just do not sit well.
What we've found is that people were coming to us having already restricted their fat because of how unwell they felt.
Yes.
But once we established them on PERT, it was a matter of, I guess, switching their brains back to I can have, fatty foods again. But just being aware that if you do have foods that are more high fat, you're going to need more enzymes.
When we started our research back in 2012, Amanda and I were seeing occasionally patients coming out who had been told within clinicians that they had an intolerance to fat, and it was obvious lack of understanding of malabsorption at the clinician level. And so we were seeing patients coming out who had cut fat, you can't cut fat out of your diet, but reduced it as much as possible. The problem being there that you've also got a reduced appetite. And so we know that with pancreatic cancer, you can have quite a significant weight reduction quite quickly. If you then restrict fat as well, there are your easy calories. And so it's increasing the risk of weight loss, but also increasing your risk of fatigue, because malabsorbing is like driving a car with no petrol in it, because the fuel can't get into the body to be used.
That's a good analogy. Thank you. And somebody said, is it, they had to ask their oncologist for Creon, but it generally wasn't offered by the oncologists. Is it something that's usually offered by sort of an oncology doctor or a dietitian or a GP, or does it really depend on your sort of area and your hospital that you're part of?
Something that Amanda and I found right back at the beginning was, in the medical field, who is going to own this? And it really varies, like you say. Amanda and I met with the oncologist when we first started doing research and asked them not to put their patients on the Creon so that we could consent them into a study. But we actually found, Amanda and I travelled around a bit. We went to the west coast of New Zealand and did a presentation there. And some of the clinicians didn't want to know about it. They didn't want to deal with it. And so it's finding out in your area who are the people that are running with it and who are the people who've got the knowledge about it that can give you the information that empowers you to take control back over your own health.
Yeah, I mean, part of this, our survey study is asking how people got put onto PERT so that we can see. And I think we then will know kind of how to target our information. So that's been quite a big part of what we're trying to kind of get information about. I think, as Helen said, it was sort of like who takes the lead on this, and probably we thought dietitians, but it's quite a specialist area. And so I think what we need to do is just shore up the resources and information for any clinician that's dealing with someone with pancreatic cancer. And I guess the other thing too is we wanted to empower patients and give them the knowledge and understanding so that they could then ask. And so we're sort of trying to come at it from so many angles so that people don't get missed.
The other thing is that in my practice, when I do letters back to the referrers, our GPs always get a copy of that if they're not the referrer. And I use that letter as a bit of an education tool, explaining what symptoms the patient had and that this is likely malabsorption and this is how we treat it, and explain the medication and the timing of taking the medication, and use that as a training tool as well. And through that, just through networking, we get GPs ringing and saying, Helen, what should we be doing here? Or have you got this patient under your care? And if not, they were referred through. And it creates a little network. So that's really valuable.
Yeah, no, that sounds like a fantastic approach, going at it from all the different angles.
Yeah.
So somebody's also asked, if you forget to take Creon at the start of your meal, is it too late to take it at the end?
You can take it directly at the end, but if it's half an hour, 3/4 of an hour after the meal, you're wasting your time. So and the other thing about it is when you start a new regime like this, and often the patients that we see have never been on medications in their lives, and this may be the first medication they've had to take, and it's it's quite often during the day you have to take it. So it's a real habit you've got to get into of remembering that I've sat down for a meal, I need to take my Creon. And so it takes sometimes a little while to get into that routine of having your Creon there or having somebody to remind you, remembering that the carer that's caring for you can be a bit fatigued as well because they're dealing with a lot of things as well. So if you forget, take it halfway through or at the end. But if it's half an hour or more after, take it next time you have a meal.
Yeah.
Unfortunately, you may be a bit uncomfortable depending on what the fat content in the meal was.
It's not dangerous to miss doses, and you do have to be kind to yourself. You've got lots on your plate. So it's just establishing those habits.
Yep.
People have told us they put notices on the fridge.
Yep.
They have, little funny boxes in their purses with the Creon on it to remind them when they look in their wallet or in their handbag. People find sort of ways of reminding themselves, but it is just establishing a routine.
Yeah. Our gentleman that loved KFC, he was a Kaiafina or a Maori health officer at a high school, and he liked to have KFC for lunch. And so he went to buy his KFC this day and had forgotten his Creon. So he ate his KFC and within a half an hour was doubled over, uncomfortable, and he never forgot his Creon again. So by default, he remembered.
Fair enough too.
Yeah.
And somebody's asked the purpose of having an assessment for PERT. Is there people with pancreatic cancer that PERT is beneficial for?
Yes, so because there's not a great test to test if someone's malabsorbing. Well, there is a great test. It's collecting up your bowel motions for 3 days. which is just impractical and nobody wants to do that. And so we know that the majority of people with pancreatic cancer are absorbing, and so we advocate at least a trial of therapy, just because not everyone realizes they have symptoms until you take them away, particularly, some of the more subtle malabsorption ones. We know that if people have been diagnosed with head of the pancreas, which is close to where those ducts are, it's much more likely. If they've been diagnosed with it in their tail, the tail of the fish, it's less likely, but not absolute. So you could make a case if someone's got a very, discrete tail of pancreas cancer, not to start them on PERT if they've got no symptoms. But we sort of advocate kind of a trial of therapy for everyone, really.
Because it's so safe.
Because it's safe, because it's well tolerated. And if people really feel like it's not making any difference, then that's fine. But we find the vast majority notice something. And that's part of the study, actually. We're asking if people noticed any changes after they started enzyme replacement. So we might actually get some of that information.
I would tend to, in practice, if it's head of pancreas, whether they're noticing, they may be asymptomatic for malabsorption at this stage, but could still be malabsorbing. And I don't want to wait till they've lost 10 kilos and then jump in with Creon. So if it's head of pancreas, I tend to start Creon. If it's body, then I would do a bit more of an assessment, but possibly do a trial. Tail, like Amanda said, it's up in the air. The other thing would be in the last probably 4 or 5 years, I've noticed there's another type of pancreatic cancer called neuroendocrine cancer of the pancreas. And we didn't used to start these people on pancreatic enzyme replacement therapy because there was another medication we tended to use to manage their bowel symptoms. However, in the last 3 or 4 years, we've actually found there are a cluster of patients with neuroendocrine that get put on that medication and are still symptomatic. And when we do a fecal elastase test or something like that, it's shown that they are malabsorbing, and we would start them on Creon as well, and they get benefit from both therapies. So certainly further down the track, Amanda and I have talked about investigating that type of cancer a little bit more as far as Creon therapy as well.
We've got lots of work still to do.
Yeah, we finish a study and find there's 5 more we could do.
I'm just aware of the time. Sorry, Sophia.
Yeah. Oh, no, that's okay. Well, there are a few more questions if you both have a couple more minutes to go through them. Otherwise, we can, try and do those at a later time. Somebody's just asked about, thank you to the person who linked to the survey in the chat. That's very helpful. And is there any issue with having vitamin C or B12 with Creon?
Not that I'm aware of, but no, I haven't come across it at all. The one thing we have, and Selena, the dietitian in Australia, and Kylie, one of our other dietitians in Auckland, we've been brainstorming a little bit around supplements and things that we could use to assist our pancreatic patients. None have specifically come up, and there hasn't been anything that we've seen that causes harm. The one thing that we have questioned, and we've emailed ourselves backwards and forwards on it, is that should we be treating our patients with fat-soluble vitamins? Because
which is not C, is it?
It's A, D, E, and K.
A, D, E, and K. Yeah.
So because it's, if the fat's malabsorbed, your fat-soluble vitamins are going to be malabsorbed. We emailed each other recently and said, should we be looking into this? And we're all a bit up in the air about it. I work solely in palliative care, so my group of patients are a little bit different perhaps to Kylie in Auckland, who sees a lot of the Whipple's curative patients. So, but we still had the discussion just to see if there's anything each of us can do to further improve our practice. And by having colleagues in Australia and in New Zealand who are working in similar areas, we can communicate with one another and upskill one another. So that's been really, really helpful. And our individual patients benefit from shared experiences.
Yeah, absolutely. Thank you. And somebody's asked if mashing food or liquid, does that make any difference to pain or discomfort?
Not necessarily, no. To dumping syndrome it may, but no. And I try and keep things as normal as possible. We really don't want families making 2 versions of the same meal. And actually being able to sit down at the table with family eating the same food is really quite important so that people don't feel missing out. So I would tend to say keep it as normal as possible, restrict as little as possible.
Fantastic. And is there alternatives if somebody has a sulfur allergy?
And now I'm only speaking about New Zealand here because I'm not sure if you've got this pancreatic enzyme replacement therapy, but the patient I recently had who had a sulfur allergy, I transferred her onto Pansitrat, which is a slightly older style pancreatic enzyme replacement therapy available here in New Zealand. And it doesn't have sulfur as a byproduct of production, so there's no sulfur in it. So I put her onto that as a replacement.
We have frozen a little bit here. I'm not sure if you can all hear me as well, but it doesn't come back in a minute. We might have to call it a day.
Can you hear?
Oh, there they go.
Can you hear us?
They might be back now.
Oh, we'll be frozen. Sorry.
Oh, sorry. Did you hear my response?
We have a lot of questions and some comments. I might read a couple of the comments just while Amanda and Helen are coming back. Somebody has mentioned from their experience that there doesn't seem to be anything other than Creon in Australia at the moment. Someone has said that they like to keep their Creon in a small pill bottle inside a frozen yogurt keeper from the supermarket because they found that the Queensland heat was causing them to melt.
Yeah.
So that's good to know. That's a good tip. Oh, Thao, you're back. Fantastic.
Yeah. Did you hear the name of the enzyme I said?
No, you froze there for a moment. So
it's Pansitrat.
Pansitrat. Yes.
Yeah.
I'm not sure if that's available in Australia.
Okay.
Somebody
and certainly
did say
the comment
that they
about,
actually did try to get something other than Creon
certainly keeping the Creon in the side of thing in the chili bag is a good idea because you really want to keep it below 25 degrees. So if it's super, super hot, which in New Zealand at the moment we're not, then certainly that would be helpful.
Yeah, it's probably a good tip for people in Queensland over in Australia.
Darwin.
Yeah, absolutely. Oh, okay. Somebody said that I was frozen, so there you go. I'm not sure which way that went, but hopefully that the information was provided either way. Let's see. I'll just have a look at a couple more comments and see how we go. I know that we're running a little bit over time, so we'll do a couple more questions and we have to leave the comments for now. So one question was about magnesium supplements reducing the effectiveness of the pancreatic enzymes. And that was just if they were taken close together, or is that they're taken at all?
Close together. Have we frozen?
I think it might be Sophia.
Can you hear us, Sophia? You can.
Okay.
It's if they're taken close together.
Okay, fantastic.
So if you're on them,
I think you're okay. I think it's just a little bit of a lag.
Okay. If you're taking a calcium or magnesium supplement, then have a talk to your pharmacist as to how far apart to have them. Can you hear us?
Okay, fantastic. And we seem to be having a little bit of a lag now, but we'll just try to more. Somebody is about being able to do with Creon protein drink.
Oh, can you have Creon with Ensure?
Yes, you need to have it. because it's a high calorie, high protein product. So generally 1 to 2 with a supplement drink. If you find that the Ensure or Fortisip drinks just don't sit well with you, changing to something like Sustagen Hospital formula, which is less fat, but at least you're getting a supplement drink going in, might be better tolerated. But most of my patients manage Fortisip and Ensure with Creon.
And there's a question here, Sophia, about are you able to take something else if you get caught out with no Creon on you? No.
No.
Sorry.
Fantastic. I don't know if...
We might have to wrap it up, Sophia. Having a few technical difficulties.
It seems that I might be the frozen one. Can you hear me okay? Or...
It's nice to know that New Zealand broadband is slightly better than Australia's.
Yep. Okay. Can you hear me now?
Yes.
Can you hear me at all now, or am I still frozen?
No, we can hear you.
It's coming and going though.
Okay, maybe I'll just say thank you for. Well, thank you so much, Amanda and Helen, and apologies if we didn't get to your questions. I'm sorry about my internet connection seems to have failed now. But yes, thank you so much. And if there's further questions, thank you for providing a way for people to ask those to you. And yeah, we look forward to seeing those study results. And if people want to participate in the survey, there's a link in the chat and also on our website. So yeah, thanks again. And yeah, thank you everybody who attended today and asked questions. We really appreciate it.
Thanks. Bye.